we're going to talk about types of blood flow, and if on page 116, if you would like to follow along, and we'll talk about these different types of flow. So we have plug flow, laminar flow, and turbulent flow. And plug flow can be found in a large vessel such as the ascending aorta, or at the entrance of vessels such as the common carotid artery. And the velocity profile of plug flow is blunt, and it's a result that every blood cell is moving together at the same velocity. So as you see on the top of page 116, you see plug flow. So it's like everybody's running together, everybody's flowing through that vessel together. As blood flow continues to move through the body, it becomes laminar, and that, looking at figure 4-7, this is represented by blood that travels in non-mixing layers. They're all at different velocities, and in the very middle is where the blood will be traveling the fastest. So when we get to that point that we need to clock the velocity, and the reason we do that is because we connect velocity or speed to pathology. So as you see with laminar flow, it's really happening in the middle is where we want to clock that velocity. High speed is usually going to be connected with some sort of stenosis, and again, pathology. So as we put our cursor in to clock this, or a gate in there, we don't want to be near the edges of the wall of the vessel, because that is the slowest flow. We want to put our cursor or our gate right in this very center of the flow, or the center of the vessel. Again, it's showing you in figure 4-8 the layers of flow, and how, again, they don't really mix, they slide over each other as they're moving through the body. Turbulent flow results when red blood cells become chaotic and disorganized, and this results in many, many different velocities. So doesn't always mean that there's pathology, because we do have some areas in our body where turbulence is normal. Let's look at figure 4-9 with turbulent flow and the Reynolds number here. So looking at this vessel, you can see that there appears to be a blockage right in the near the walls of the vessel. This blockage in our patients, if we're thinking this could be the carotid, would be sometimes atherosclerosis. And I know I'm not saying that very well, but it would be like having cholesterol and plaque building up on the wall of the vessel. And so what happens is the lumen itself will narrow. So when this happens, again, all the blood will have to come from one side of the vessel that is normal, go through this blockage, partial blockage, and then come out through the other side. And as you see, again in figure 4-9, that as the blood moves through, it will pick up speed in the middle, and then when the vessel opens back up, then you're going to have some turbulent flow as it comes through on the other side, even some reversal of flow. Sometimes turbulence also occurs from tortuous or large vessels that may loop around itself, or even a kinked vessel. So it may not always be due to disease. It could be just due to the size of the vessels, or if the vessel kinks on itself. Also could be due to some kind of thrombus in that area. So again, we need to quantify this degree of turbulence, and this is called the Reynolds number. The Reynolds number greater than 2000 is considered to represent true turbulence, and this would be a fact that I would put to memory and you're going to be using it the rest of your career. Before we move into the continuity equation and Bernoulli's principle, let's look at figure 4-10, and this would be a normal type of turbulence that occurs in the carotid bulb. So as you see the blood flow moving through the vessel splits. One goes up to the brain and the other feeds the face. So the internal carotid artery and the external carotid artery. And so with this, there is this safety mechanism where there's what we call the bulb. And the bulb will kind of make sure that that blood is slowed down before it enters into the brain. And so in this area, as you see in the image or the picture, that there will be some backflow and circular flow, which is turbulence. But this is an area of the body where turbulence is normal. Again, this bulb is usually is in this place just to make sure the blood doesn't go too fast into the patient's head or create a stroke situation. Moving into the continuity equation and Bernoulli's principle, we have to remember that there is a finite amount of blood or liquid that is in the closed system of our circulatory system, and at any point along the way the volume must remain the same. So then we have things like a stenosis or maybe a thrombus or maybe a kink, and so what has to happen is as the blood enters into this narrowed area, is something has to change so that the blood coming into that area and the blood coming out on the other side, that the volume remains the same. So looking on page 118 on figure 4-12, we see Bernoulli's principle. So what's going to happen with this narrowed lumen or this stenosis, the blood will need to speed up to get through the stenosis and then slow back down on the other side. In order for this to happen, there has to be a decrease in pressure through the stenosis. So that will transfer that energy from being high pressure energy into velocity, so that in that area there'll be low pressure and the velocity will pick it up. When the high velocity blood enters back into the normal size of the lumen, there will be another exchange of energy from high velocity back to low velocity, and that will therefore increase the pressure on the other side. So you could say that this is an inverse relationship between pressure and velocity, and this is linked to the law of conservation of energy. Any increase in velocity is an increase in energy, and therefore the pressure must decrease to preserve that total energy. Once the vessel goes back to its pre-stenotic area, there is a decrease in velocity with a corresponding increase in pressure. Again, that energy has to be accounted for, yet we have to use the continuity rule to make sure that the blood volume stays the same. We're going to talk about Poiseuille's law. So this is another law or factor that can increase or decrease the amount of blood flowing through a blood vessel, including the length of the vessel, the radius of the vessel, and the viscosity of the blood. So if we apply these three things, this will be, again, considering Poiseuille's law. This law describes the relationship between the volume of blood flow and resistance to flow in any blood vessel. With Poiseuille's law, it is important to remember that the human body does not have a lot of straight lines as far as blood vessels. We have a few, but remember Poiseuille's law is about straight vessels. So we're going to consider some of the things And then there'll be some of the things that the law says, but the thing I would like you to remember is that last bullet point, where in fact, if the radius doubles, flow increases by a factor of 16. So an increase in length or viscosity will decrease the flow, while an increase in radius will increase the flow. And to me, that's the most important part of this law. And we do need to remember that inertial losses are going to occur as the vessels branch and change direction. And of course, another form of resistance is friction. And this is loss of energy in the form of heat and is another detriment to flow. As the arterioles branch out into capillaries, frictional and inertial losses are responsible for the accompanying decrease in the velocity of blood. The slow flow, again, as the vessels get tinier and tinier and get to about the width of a red blood cell, the size contributes to the energy loss and the slow velocity of flow. But this is essential for the function of the capillaries, which is to exchange nutrients and waste products. As we said earlier, Poiseuille's law does assume a straight and rigid pipe. And we know that the human body is not that way. The human body is very curvature, and but what it does do is it demonstrates the relationship of flow and resistance. So that would be the most important takeaway here. And here's our other takeaway. The heart continues to beat and pump the same volume of blood, regardless of the presence of a stenosis downstream. But there can be a stenosis so severe that it compromises flow to a certain part of the body. So, of course, in our work, we're going to be looking at the carotid arteries because we do like to have blood in our brain so we can operate, or function well. But then again, there could be other things like thrombosis and pathologies that we do need to monitor until a plan of action is put in place to make sure that body part does not suffer. As we're monitoring our patients, if we reach a critical stenosis, that would mean that there is a hemodynamically significant stenosis in one that which there is a decreased distal flow. This situation would lead to a significant pressure gradient. So here would be your number here. A cross-sectional area loss of 75% is generally considered to be hemodynamically significant. And again, this means there would need to be some intervention by a physician, possibly surgery, to get the stenosis out of this critical stage. Blood vessels can be connected end to end in a series or flow into multiple parallel channels. The effective resistance, the resistance of the distal bed, is the sum of all these individual resistances when multiple vessels are connected in a series. So when vessels are connected in parallel, the effect of resistance is reduced because there's more channels and paths for the blood flow to move through. And the good thing about this is why patients will develop collateral blood systems. There's a stenosis in an area, so collaterals will begin to form to move that blood on down the path. Now, some people ask, well, where do those come from? I mean, you just don't grow them, do you? And what happens is you do, when you were a little embryo, only certain vessels matured, like into the heart, into the aorta, and all of our major vessels. So there's still some of those embryologic remnants there that can grow and appear as our patient needs them. So again, stenotic flow can trigger the appearance and the development of collateral circulation. So again, resistance and stenotic flow. Arterioles do have muscular walls, and then we have the innervated arterial walls can constrict and dilate with response to signals from the brain to either increase or decrease flow distally. And again, the velocity of the blood cells must increase in order to maintain that same volume flow. So connecting this to what we do in ultrasound is, since the velocity must increase to keep the same volume of flow, our job will be to monitor velocity. And that's what we're going to do with our equipment. Again, remember, increased speed is going to equal pathology. It is vital to recognize that blood will always follow the path of least resistance. So if a major artery is blocked, it becomes the path of highest resistance, while previously collapsed collaterals become the path of least resistance. Higher pressure is proximal to the stenosis, causes the collaterals to open up, and the blood follows the lower path, lower resistance path. Distal to the stenosis, the collateral eventually will rejoin the main artery. In chronic disease, the collateral network is extensive enough. The net flow distal to the stenosis may actually be normal. These collateral circuits can really be very complicated, but we have to remember that they are also not strong arteries. They're more of a weaker artery, and they are subject to bursting. And remember that these collaterals are not found in an acute obstruction. This is something with chronic disease that over time these collaterals will open up and move the blood through